Well, in this week's Cardiology Countdown, we'll start with the BARC. The BARC Bleeding, or Bleeding Academic Research Consortium, came up with a standardized definition as a way to try and normalize the rates of bleeding across different trials and registries. And the ISAR group pooled over 12,000 patients from their 6 large trials and looked at the rates of bleeding according to BARC, TIMI, and replace, finding them in the range of 4 to 5% for the major bleeding category, and then looked at the risk of dying if you did have a major bleed, which is known to be increased. And with the BARC score of greater than or equal to 2, it was about a 2.7-fold increased risk in mortality. And actually similar increases were seen with the replace 2 and TIMI criteria. And so this is a nice validation of this standardized definition of bleeding that trials can use moving forward. At the number 2 spot is a very nice study done in outpatients with heart failure using a multi-marker biomarker strategy. This was a group of 1,500 patients seen in an outpatient setting, followed for 2.5 years, and they did a multi-marker panel including CRP, myeloperoxidase, BNP, FMS like tyrosine kinase receptor 1, never heard of that one, troponin I and ST2, as well as creatinine and uric acid. When they did a multi-marker strategy and added that to the risk prediction done from clinical variables, they found that the C statistic went from 0.75 up to 0.80, and they reclassified into a high-risk group about 25% of patients. And so a nice demonstration in outpatients that a multi-marker strategy can be very helpful in heart failure. And the number 1 pick is a randomized trial of a pretty hot topic, looking for evidence of atherosclerosis. This is a randomized trial of about 500 smokers that did carotid ultrasound screening for plaque in half the patients. Then they looked at whether there was a greater rate of smoking cessation amongst those who had the screening, of whom a good percentage had evidence of coronary plaque. And unfortunately, they found no difference in smoking cessation. Rates were high, nearly 25% in this study, but no difference if patients were told that they did in fact have plaque. Thus, a modest-sized study, but bringing some caution into the concept of whether screening would help identify patients and have them be managed better. More work in that field is certainly coming, but one initial randomized trial with a note of caution. So for this week's Cardiology Countdown, I'm Chris Cannon.